So today we'll talk about pain, spine health, spine surgery, as well as the diagnoses and the treatments of that. The one thing I wanted to mention at first, and I don't know how many of you are lifelong residents, but I think we have to give a shout out to Ed Moransky for his work in this building and restoring it back to the 1957 era, just in this auditorium. From where it started to where it is now has been a real asset, I think, back to our community. And I think it's a really neat thing to see. If you walk around this building, just some of the history and some of the original pictures that exist down the wall of how this looked on its original build in 1957 says a lot to the efforts that were put into redoing this. And I think as a lifelong Youngstown guy myself, I appreciate those kind of things. Man. So to get started, Dr. Engel will speak with you. And Dr. Engel does physical medicine rehabilitation as his specialty. He is a graduate of our Northeast Ohio Neomed here and did his residency at Ohio State. Been in practice in the area and joined me at the Pain Center here a few years back. And the thing that I think people don't appreciate is that we have in this area a facility where people that do diagnostic medicine and testing can talk with people that do intervention, that can talk to surgeons, and we all exist in the same office group. That's as opposed to going to Cleveland to get an opinion, then to Pittsburgh to have a surgery and back. And I think to the area, that was our goal when we put this together, was to be a comprehensive facility where we could provide people in our Youngstown area with all the resources they need without running all over to get them done. So I'd like to introduce Dr. Engel, who will speak with you a bit. I'll come back and speak with you as well, and then Dr. Grisafi will. And at the end of that, we'll have some time for question and answers. Okay, so thank you. There you go.
Thanks, Dr. Gamla. Thanks everybody for coming. Appreciate good crowd really today on this beautiful afternoon. I'm sure you could be enjoying the weather. So as Dr. Gemma said, I was in practice with Dr. Yarb and Dr. McGrath at All Points for many years. And when Ed put this team together underneath an umbrella, it was an opportunity that we had been looking for many years. There's a lot of benefit of having multi-specialties under one roof. And I think when you sort of see how all of us talk today, you get a kind of sense of that team approach. And I think at the end of the day, that's what helps all of you guys. So we're going to talk today about back and neck pain. And I'm a physiatrist or physical medicine rehabilitation specialist. So I'm going to talk a little bit about our role in the center, but just to get started, a little bit more about why a pain and spine center is so important. There are literally 50 million patients out there that have chronic pain, and that's not to mention the many millions more that at any given day, week, or month deal with acute pain. And both of those are things that we take care of here at the Spine Center. We've got a wonderfully remodeled building. If anybody's been there, hopefully you can appreciate how nice it is. And it's, as I said, all under one roof, the entire team. So you've got physiatrists like me, PM&R specialists. We have anesthesiologists who do pain management. And we also have surgeons all under that same roof. And together, we form the team that takes care of patients for the continuum of care from conservative all the way to surgical. So what is PM&R? So there's not many of us in the country. There's about 5,000 of us total in the country. And it really was two specialties that came together. There was physical medicine, which is sort of what it sounds like, right? It's, the backs, the shoulders, the hips, the knees, all the joints and the muscles, as well as the nerves that allow our bodies to function. And then rehabilitation medicine. So all of us probably know somebody who's had a significant injury, either a head injury, a spinal cord injury, a stroke, and then needs to stay in the hospital and do some rehab before they're able to go home. Those are physiatrists that are heading those teams. And so those two fields come together to form physical medicine and rehabilitation. And if you could kind of say in a sentence what we do, we essentially work to restore function. So whatever you've lost, we're working to get you back. We can diagnose and treat pain no matter what the cause is because of sort of the breadth of our background of the neuromuscular, the joint, as well as the rehabilitation medicine. And so our role at the Spine Center is essentially when patients first present and say, hey, I've got a problem, we see those patients, we evaluate them, we take a history from them, we do an exam, a comprehensive exam. I've had a lot of patients say to me, I've never had a doctor examine me that well in my life, which is interesting. We look at your history, you know, what's happened to the past, what surgeries might have led to where we're at today. And we also look at your family history and how that may play into what's happening. And then we essentially determine, well, where's that pain coming from, right? Is it your neck? Is it your hip? Is it your knee? Is it your shoulder? We're going to focus today mainly on the spine issues, but as physiatrists, we do treat all of those other areas of the body non-operatively as well. And then we put together a treatment plan, right? So we say, all right, what are we going to do here? And we'll talk about that a little bit more in depth. And then we institute that plan, and then, you know, we have you come back and we reevaluate and say, how did you do? And we determine, you know, what has to happen next. Sometimes the next thing that has to happen is referral to anesthesia pain management. Hey, this isn't just fixable, we've got to manage it differently. Sometimes it's surgery, and sometimes it's just changing maybe a more conservative plan to a different way. So specifically talking about back and neck pain, how many people here have had back pain in the last 2 years? Ha ha! How many people have had neck pain in the last 2 years? Well, you are not alone, right? How many people at this moment have one of those two things? Right? So yeah, I figured we'd have a higher population here, but I mean, this is just prevalent. I mean, we spend some $80 billion a year in the US alone on treating spinal problems. So it's prevalent, and then somewhere around 8% end up with persistent problems. So what do patients come in and complain about to us, right? Hey, hey, I'm here, doc, what are you here for? Sometimes we're talking about dull, burning, sharp pain. Sometimes it's, hey, it hurts right here. Sometimes it's pain all over. Sometimes it starts here and it goes somewhere else. And all of those things mean something different to us. Sometimes we will have associated numbness, tingling, or weakness with those pain. And again, that directs us down a different road in our diagnosis of what we think is wrong. Sometimes, how many people get stiff or achy in the morning? You know, good old Arthur, you know, he finds his way into our lives. Sharp shooting pains, pain when you're trying to roll over in bed. I hear that one a lot, you know. And then also, hey, I sit, and then when I get up, it hurts like the heck, or other times it's I can't sit for very long. This is a very common one. Hey, I can walk so far and then I have to stop. I just can't make it any further, right? I have to sit down. And those are all indicative of different spinal conditions. So let's talk about some common ones. So we'll first talk about cervical radiculopathy, which is neck, you know, that's your cervical spine. And radiculopathy, you might hear it more as layman terms as a pinched nerve. And so there's some common patterns of, you know, pain that sort of starts in the neck or the trapezius or shoulder region, then goes down into the arm. And depending upon which nerve is involved, C5, C6, C7, C8, you'll kind of get different pain patterns. A lot of times we'll get shoulder blade pain with a pinched nerve coming from the neck. Lots and lots of patients end up in the Pain and Spine Center because they first presented to an orthopedist in our group that said, hey, I think I have a shoulder problem. And then the orthopedist says, nope, that's not your shoulder, that's your neck, go see those guys. So that's not uncommon. Same kind of thing can happen coming from the low back. We call it lumbar radiculopathy. You might hear it be called sciatica, you know, pain that starts in the back and shoots down the leg. And again, the pattern of that pain tells us where we think that's coming from. So anywhere from L3 down to S1 has a different pain pattern as far as where it goes. You know, if it's going into the front of your leg, it means one thing. Down the back of your leg, it's a little bit different thing. Another less commonly known pain pattern that we see are facet pain syndrome. So Our spine is made up of little bones stacked all on top of one another with discs in between them, and those bones are connected by joints, and those joints are called facet joints. And so those joints, just like an arthritic knee can hurt or an arthritic hip can hurt, if you have an arthritic joint in your back, that can hurt as well. And these are some different pain patterns that we see from those. And then we get these kind of problems. Anybody here that has fibromyalgia problems, right? So fibromyalgia patients, I feel so horrible for. I'd say it's like your pain has a microphone and it's distorted, and then all your pain seems to go everywhere. So those are other things that we treat there at the Pain and Spine Center. And then there's symptoms that we don't necessarily think about when we're coming in. We talk about the pain, but then you start to think about how that affects your day-to-day life with restrictions in what you're able to do, your mobility. I can't tie my shoes, I can't get in and out of the car. You feel, I don't want to go to my grandkids' baseball game because I'm worried I'm not going to be able to get there and get back. And so, these things impact our quality of life pretty dramatically beyond just the pain itself. Sometimes I get this question, when I'm talking to friends and family, they'll say, I've had this problem for a while, when do I got to go see you, And so I think some good rules of thumbs is, I think everybody's entitled to have some pain for a day or 2 or 3, but if you're 3-4 weeks into it, let's get it figured out and get rid of it. If you've got bad pain and it doesn't improve when you take a break, that's something that's a little worrisome. Again, we talked about things that spread down the arms or legs. Those are a little bit of a red flag for us. It lets us know there's usually nerves involved that we got to worry about. Certainly weakness, numbness, or tingling is a reason to come see somebody. Those are, again, indications that you've got some nerve getting irritated or inflamed, and we don't want an irritated nerve to become a damaged nerve. Weight loss or fever, bowel or bladder problems, or if it follows like a big injury, right? If you fall off a ladder and you're hurting, you better get it checked out, right? So what, a lot of patients will ask, what did I do, doc? What do I do wrong to have all these problems? And first of all, you didn't do anything wrong. As you saw from the beginning, everybody at some point or another is going to have problems, right? But some risk factors we know of are lack of exercise, weight, posture, smoking, obviously as we age. And then, lifting problems can get us in trouble. But the reality is if you spent, a week in any one of our offices, you're going to find old people, young people, heavy people, skinny people, tall people, short people, people who sit all day, people who work all day. It's just that prevalent. So we talk about different types of injuries or causes of pains. Sprains and strains, those are the common things, right? I lifted something, it twisted a little funny, and it stayed, the pain stays in the back. Some more concerning ones are fractures, disc bulges, if that disc starts pushing on a nerve. And then you can have things like spinal stenosis or scoliosis. Those are, again, structural problems with the spine. Open, then it gets quite narrowed there. And again, open here, narrowed there. And that's a classic case of that, hey, I can only walk so far before my legs stay, I gotta sit down. So there's different types of arthritis. The good old Arthur that we talk about all the time is osteoarthritis, and then there's other types of arthritis that involve your immune system, like rheumatoid arthritis, or there's a condition called ankylosing spondylitis. You can have tumors or infections. This is another example of where the bones don't stack on top of one another properly. And when that happens, we have a big fancy name for that, spondylolisthesis. Again, that can happen in the neck, which is here, or in the low back. And then it's always important to understand, when you think your back hurts or when you think your neck hurts, it doesn't always mean it's your back or your neck. It can be a hip or other areas in the pelvis that cause your back to hurt. And these are just some things that can do that. A common, as I mentioned before, is shoulder, neck patterns of pain that overlap. And then we already talked a little bit about fibromyalgia as well and how that plays into all this. So what's going to happen when you come and see me or one of the other docs there at the Spine Center? We do an initial consultation. We take your history, talk to you about what's going on. We all heard these questions. We use the acronym PQRSD. Where does it hurt? The quality of the pain. Where does it radiate? How severe is it? Give me your pain scale. And then we do an exam to see if we find any of those neurological deficits or weakness, range of motion of joints. And then we may do imaging, sometimes x-rays, sometimes MRIs, CAT scans, or even ultrasound imaging. One of the things we do as physiatrists that's unique is we do electrodiagnostic testing. If you've ever had that test where we shock you and poke you, we're looking at the health of the nerves for carpal tunnel or pinched nerves, we might do that. And then we basically create a plan. And when we talk about that plan, we typically start with conservative things. How about some physical therapy? How about some over-the-counter medications? Do some stretching at home. Sometimes we see patients, and once we've done our workup and we've said, hey, this isn't anything horrible, you've got some stenosis, they decide, I don't know if I want to do anything. I'm just going to live with it. Now I know that I don't have cancer, I'm going to just live with it. And that's okay too, because no one's ever died from back pain in the history of the world, right? And then as we get the more advanced, we can talk about prescription medications. There are spinal injections, and Dr. Gemma's going to talk about those in more detail. Those are things that we do as well. Epidural injections. I think somebody said they had an epidural for me. I heard earlier. There's procedures called radiofrequency ablation that you'll hear about. And then we get even more advanced into spinal cord stimulators or things like platelet-rich plasma. That's sort of the stem cell regenerative medicine world. And then obviously, if all of these things can't get us where we need to be, or if there's other reasons that lead to a more emergent reason, then we can talk about spine surgery. So with that, I'm going to pass this off to Dr. Gemma and let him kind of continue talking a little bit more, and we'll be back at the end to answer any questions. Thanks.
Okay, thank you. Back with you and talk a little bit about some of the injection medicine that we do as part of the initial treatment as Dr. Engel has lined up as far as what we go through in diagnosis, what we go through in our initial evaluation, some of the more conservative measures of medication management, physical therapy. That is so important. I've been doing this now for over 32 years, and thank God I started when I was 10. So I can continue to do it now, but I would tell you that probably 95% of my patients can't stand on one leg. And that's an amazing thing. It's all balance, and then the balance leads to pain. And people will say, well, how did I lose my balance? Well, the injury sets you up for that. The injury sets you up to guard and decondition yourself so that, okay, if I hurt a knee, I hurt an ankle, I hurt a hip, then I'm carrying myself in a different way. And then all of a sudden I get a back injury. Now all of a sudden I lost my ability to hold my flexion or extension of my leg, and I've lost my balance. So working with balance, I think, is very important, and I'm a big proponent of that with my patients, and I tell them all, part of your day can be spent doing that. I have a very simple, looks like a stop sign device with a half a ball underneath it. And you could hold on to a counter, you can hold on to the world if you need to. But just to be able to go in all directions and dimensions with that balance helps you retain that ability. And I tell people, if you do that every day in 2 weeks, you tell me you don't feel better. And I've yet for somebody to tell me that they don't feel better after 2 weeks. So that's an amazing thing we can do to kind of help ourselves. And I'm a big believer in that as well. I hope to help people help themselves. I think we all have that philosophy in medicine. And I think at the Spine Center, we all try to make that point, is that it's very important that we all try to help ourselves in the process. So we'll talk a little bit about the pain management that Dr. Engel has already spoken with. So we do, from an anesthesiologist and a pain practicing physician, we're trained in doing injections and medication management and the like. So we'll talk a little bit about those injections today. Just to give you an overview quickly, the spine looks like this, and this would be as if you were standing up there and looking down on my head. So this is the disc material back here. This is the spinal cord here with the exiting nerve roots. This is that bone that we all see when we look from the side. called the spinous processes that stick out. So basically the function of those bones and the discs is to protect that very, very important nerve that we have running from our brain to our tailbone, and that's the spinal cord. So it exists in that canal. The anatomy is that we have cervical vertebrae, thoracic vertebrae, lumbar vertebrae, and then we terminate to the sacrum and the tailbone at the very end. So we'll go through a couple case scenarios, and I think that describes the injections we can do, and I think it describes why we do those injections. So take this patient as a 72-year-old female. She comes in with low back pain, burning and numbness and tingling all the way down the leg. That's what we call radicular pain, okay? The past medical history, the patient has heart disease and also has gout. And the physical exam, the findings included decreasing strength and sensation of the right lower extremity. So when we look at that, there are certain nerves that come out of our back, and the lumbar spine have 5 different levels of where they can come out. And each one of them has their own roadmap, okay? There's the S1, the L5, the L4, 3, 2, 1, as it goes. So they give us that map, and the patients, if you talk to them long enough, they tell you what's wrong with them. That's the key in patients in medicine. You know your body, you know yourself way better than we do. If we just keep asking the right questions, we can get to the real root cause of what we got going on. So this patient has what we call radicular pain. And Dr. Engel showed you that MRI. Well, here's an injection that we can do, and you can see the dye and the needle going right here between the L4 and the L5 vertebrae. And that's the nerve root right there that is the culprit of the right leg pain the patient has. So those are epidural injections. We can come in from the side. We can come in from the center. We do them from the neck all the way down to the tailbone. Okay, we can access that epidural space at every level along the way. It's important to get close to the affected level, but it doesn't have to be necessarily at that affected level if you're going from the center. When we go from the side, then we obviously are very particular about which level we go to. So the steroid is what we inject. So we look with x-ray, we want to make sure we're in the right spot. We inject that steroid. Well, what does it do and how long does it last? Every steroid is different. Some can be in there up to 6 months. And Dr. Grisafi can tell you that when he's looking in the spinal canal at surgery. If the patient had epidural steroids before, you could still see steroid particles in there up to 6 months later. So when people ask me how long this is going to work, I tell them it's in there for a while. I can't tell you how long it's going to work, and it also depends on what you're going to do in the meantime. So we put the epidural injection in, and we encourage you to go to therapy, to continue the stretching, to continue those exercises that you do. It acts to help shrink the swelling around the spine, coming from either the back part of the spinal cord or from the discs themselves. And when you shrink the swelling, then those nerves can get their nutrients better, okay? So that helps the body heal themselves. If you think of a nerve, it's kind of like a hose where there's flow within that nerve, and the outside has, if you kink a hose, you don't get enough flow. So the idea is to try to reduce that kink by providing an anti-inflammatory steroid. The other blocks that we do, you hear them have, I had something burned or I had something frozen. Those are called, they come with a medial branch block or radiofrequency ablations. And those are done at certain levels that may cause pain. And in this scenario, it's a person that presents with back pain, stiffness, and it's localized to the back. It doesn't radiate, okay? It doesn't have what we call that radicular or the radiating pain. It's more isolated to the back itself. So we look to those levels. We'll go in with a local anesthetic, and we'll inject that local anesthetic. And we tell the patients, go home and do what you normally do. If that injection of that local allowed you to move about your day in a lot better manner without pain, then it's telling us that that needle location was very precise in helping you get through that pain. If we go in again with a special needle that can either freeze or burn, depending on the nerve, we can go in there. If we wipe that nerve out for a year or two, it's going to significantly improve that pain that you had. So the local is kind of like the test, okay? It's to see if your injection is going to work. And here's a case where you can see the arthritic change just in the cloudiness of this x-ray versus this, which looks a whole lot better, and it's much more organized. Here it's a much less organized, and the cushions in here have really deteriorated in that view. So those are the little needles that we stick in, and we do the trial of the local injection, and then we do a special burning if we need to of those nerves if that local worked. The other joint we hear and we've heard all of our lives is I've got the sacroiliitis. I love that term. The sacroiliitis is basically a joint in the low part of where the back meets our pelvic bones. And that joint can be very painful, and something simple, and it's usually an easy motion, like I went to pick up a piece of paper from here, I came across my body, and boy, my back hurts. It really hurts when I change position. It's probably one of the most underdiagnosed conditions that we have in this country. That joint can cause so much pain, and it's almost like I'm okay when I'm just sitting or I'm just standing, but when I go to move in one direction or the other, boy, it feels like somebody sticks a knife in me. So we do those injections, and we could even do a burn or an ablation to that level, which significantly helps patients. Okay, so both the injection of a steroid, which I actually have done on myself. It's not that hard, it's just hard to reach back that far sometimes. But I wouldn't, nobody else would do it for me. I think they were afraid. But, so I did my own, and it worked out just fine. So those are some of the injections we do. This is the injection where we go in with a burn. So you see there's a little cable that goes onto this and the very special nerve needle that has a tip to it that allows us to do the ablation. So the last thing we'll talk about is this. Dr. Grassafi, this is a great lead-in for Dr. Grassafi because this talks about spine surgery here. You see people will say I have screws and bars, or some people will call them cages, and those are a little bit different. But this is basically a spinal fixing device here where these are screws and these are bars, and they hold these bones together because in the past they either had them slipping forward, causing a squeezing down of the spine, or sliding left to right, which can cause the same problem. So this is basically what we know as a spinal fusion, okay? So the stimulator is if you have the spinal fusion and say 5 years later, there's nothing else to fuse, there's nothing surgically to do, we've tried all of our therapies, we've tried our medications, and we still cannot get you help. You still have that burning pain. These little tiny catheters can be placed in the space, on the epidural space in the spine, and they can provide a very low current of electricity. And that fools our spine into masking that pain. Now people say, oh, I can really hurt myself. You really can't. The idea is that it's just the sensory fibers of the spine, and you're trying to mask the pain that keeps constantly being bombarded to the spinal cord. And this is what they look like. It's pretty impressive. In 30 plus years of doing this, when we first started putting them in, it looked like you were putting 2 battery cables in people. And now it's a multi-lead controllable device. It almost looks like a little pacemaker that are implanted, and you can use a magnet to turn them on, turn them off, or adjust them, even by phone. So they've really come a long way. The last part about this is medication management. We obviously don't want to put, we all understand in this room that there's an opioid crisis in this country. Prescription medications, and physicians like to get the blame for a lot of this. Most people don't realize that back in 2008, they had a mandate on us as doctors, and that was part of the initial Affordable Care Act, that we were judged and we were actually compensated based on how we gave patients pain medicine. And when you left the emergency room and you got a script for pain medicine, they wanted to know, did you get enough? Okay? And then they realized this was a really bad idea really quickly. We always knew it was a bad idea. Hooking how you're going to pay somebody based on how many pain medicines you give them. And we quickly got away from that, thank goodness, but it has caused part of this problem. Properly taken with a contract with your physician saying that you're going to take pain meds just from them, that is the proper way to manage pain and manage opioids or pain medicines. Not everybody needs fentanyl, not everybody needs Dilaudid or morphine or you pick, okay? So we will manage those with you. Now, when you sign that contract with a doctor that's writing your pain meds, you really have to always adhere to that. If you go to another doctor and he gets you pain meds, then you're broken that contract. The state board comes down on us for that. That's why we have to monitor it. It's not like we're trying to put people into a category. It's not that we're trying to give people a certain box that they have to live in, but that's just the rules of the game currently. We'll see going forward as it changes, we'll see what to do, but we have to have those contracts with patients in order to write pain meds. The bottom line is there's a lot of other things we can do short of narcotics in managing pain, and that we here will all do those things to help. Drugs like Neurontin and Lyrica. I started with a group of physicians in Columbus, Ohio in 1995 when nobody was writing for a drug called Neurontin or gabapentin. 8 of us sat around and talked about how we used it on patients and what kind of success we were given. And from that, I think we were the first 8 in the state writing it back then. And it's just blossomed into a whole lot of people across the country are getting this drug. It acts as kind of like black tape around a nerve. All right, like if you have an electrical wire that's short, put black tape on it, it stops the short. Same kind of thing works for the nerves. So that pretty much covers the interventional part of pain management. And now I have the pleasure of introducing Dr. Frank Grisafi. Dr. Grisafi is a spine surgeon that came to Southwoods a few years back. He was practicing in Pennsylvania. He had gone to medical school at Thomas Jefferson and then did his spine training up at University Hospital in Cleveland. Great guy, love working with Dr. Grisafi. He is very reachable. There's a lot of times I see a patient, I say, hey, what do you think of this? Can you pull up the x-rays and tell me what you think? Where can we go with that? And people in this area don't realize the gift that that is. I mean, as opposed to me calling Dr. Kalfas at the Cleveland Clinic, who's a great guy, and I've known him for 100 years, but it's going to be 4, 5, 6, 8 weeks before you're seeing. This can happen in minutes on a phone call or a text or a reach out across the hallway. So I'll introduce Dr. Grisafi to you. I'm sure you'll enjoy him, and then we'll have a few minutes for question and answers when we're done.
Thanks, Tom. All right, welcome everybody. Thanks for coming. So I'm tasked with the easy goal of trying to explain all of spine surgery in the next 15 minutes. So hang tight. So obviously I can't get through all that stuff. We'll hit on some key points on sort of who needs surgery and some specific examples of different types of surgery we do with some focus on some minimally invasive surgeries that I do to try to give you guys a general idea of the things going on here. So Dr. Gemma and Dr. Engel did a nice job of explaining some of the conditions and how those are treated non-operatively. And most patients will get better in 4 to 6 weeks of non-operative management. Probably, just statistically speaking, 80% to close to 90% of patients can be treated successfully non-operatively and not need to have an operation. And then, the 10 to 20% that don't get better end up seeing me. So who needs surgery? When should you consider a spine operation? Well, the nice part about being here is a lot of the workup is done by our PM&R doctors and pain management. And if they feel you're not getting better, they've already done all that work, and then you come to me and I can see what they've done and we can make a decision. So if you failed that conservative care and you're still having severe intractable pain that affects your activities of daily living, your quality of life, then it's time to think about an operation. And those are sort of elective type operations where you're still functioning, but it could be better. Now, if you have a neurologic deficit, that's kind of a broad term, but if you're pinching a nerve root or you're even worse, your spinal cord itself, that can cause significant weakness, trouble with walking, trouble using your hands, along with severe pain symptoms as well. So if you have a neurologic deficit that's significant, it probably needs to be addressed surgically before it becomes permanent or gets worse. If you have instability of the spine, whether it's from a degenerative condition like the slip disc that Dr. Gemma showed in a picture, if the spine is translating or rotating, then the bones can shift into your nerves or into your spinal cord and cause a problem. Obviously, if you fractured a bone in your spine and it's unstable, then that needs to be stabilized. In rare cases, if there's tumor in the bone that's causing instability, it needs to be removed, and occasionally we see infections in the spine that need to be operated on. One of the other nice things about working here at Southwoods, we've talked about the team approach. We have well-trained surgeons here. The hospital itself, if you ever had to have a surgery, I mean, I would want to have my surgery here. The facilities are nice, as you can see in this building. All the buildings look like this. The rooms are clean. It's a private room. The nurses are very good. The food is good. You go home with a hot meal. So patients, and that's important, the food being good. So patients really like coming here, and it really helps the whole patient experience. Which helps me as a surgeon if patients feel confident in the hospital they're staying in and the nurses and all those things. And it mitigates issues with pain control and other possible complications after surgery. So spine surgery in and of itself sounds complicated, but you can really break it down to two things. There's really only two things you can do to the spine. You can decompress the neural elements, the spinal cord or the nerve roots. If there's a herniated disc, bone spurs, or the spine is shifted and is pinching any of those structures, you can decompress. You can remove bone and soft tissue to get pressure off those nerves that are causing pain and weakness down your arm or leg or causing neurologic dysfunction. You may have heard surgeries like a discectomy, that's removal of a disc herniation, a laminectomy, which is removal of those bones off the back of the spine that protect the spinal cord and nerves to open up the spinal canal. A laminoplasty is a procedure. Instead of removing the lamina, we can actually make a partial thickness cut on one side and a full thickness cut on the other side of that lamina and open it up like a door and hold it there, and that creates more space for your spinal cord. The only other thing you can do to the spine is basically stabilize it. You can put those screws and rods in it like you saw in the other picture, and stop it from moving. You can use those instruments to manipulate or move the spine or shift it or straighten it out and then lock it into that position. So those are really the only things you can do to the spine. And sometimes we do one or the other or both at the same time. So getting into some specific types of surgery, a very common neck surgery performed called an anterior cervical discectomy and fusion. You've learned some of these terms already. This is a procedure that is usually performed for a patient that has a herniated disc in their neck or bone spurs or stenosis that's pinching on their spinal cord and or nerve root. And the way we do that is we make an incision on the front of your neck. It's nowhere near that big. This is not a very good picture, but it's a small incision, transverse. We can access the front of the spine relatively easily, remove an entire disc, remove any bone spurs, and to make more space for your spinal cord or exiting nerve root. And then where the disc was, that space, we put a spacer with bone graft in it, and a plate with screws in it, and that fuses it together. So there's a decompression part of that, removal of the disc, the decompressed nerves, and there's a fusion part or stabilization part with bone graft, spacers, and plate and screws. This is an example. In this picture, you can see these discs are fairly degenerative. They're narrowed down. This is a more normal looking disc up here. So these two discs look pretty bad. We'll remove all that stuff, the bone spurs in the back. This is an example of a cage or a spacer that holds that disc space open. And then these are the screws that go through this plate and hold it there. And eventually the bone will heal across and fuse those discs together. That surgery takes about 2 hours. It's not a terribly painful surgery. It's a good way to deal with some of these problems compared to going to the back of the neck. Tends to be a more painful operation. Taking all that muscle off the bone in the back of the neck can be very painful. So if we can get to things from the front and get things better with that approach, it's a little easier on patients. An alternative to that is an arthroplasty. And that is, if instead of fusing the disc, you can put an implant in there and maintain motion. It's basically the same operation. It's the same decompression part of the operation. You know, where this disc was, you remove the entire disc, just as the other procedure, but instead of putting a spacer with bone graft in it, you put basically a joint. And this allows motion, so it's a motion preserving operation. The advantage of that is you don't have to achieve a fusion, so some of those complications where if the bone doesn't heal or doesn't fuse and you got to do another operation, you don't have to worry about that. And you know, the other advantage being it does maintain motion. Now theoretically it can help protect the segments above and below. So if you lock up one disc in your neck, then theoretically the stress is transferred to the disc above and below and can cause advanced degeneration of those discs or accelerate that process. Some of the more recent studies are showing that that's starting to pan out a little bit. But this is not everybody's a candidate for this surgery. There are certain indications. You really have to have one or two bad discs and the rest of your spine has to be fairly pristine. If you have other pre-existing arthritis, especially in these joints in the back, if people have a lot of arthritis and you maintain the motion, then it just keeps rubbing in the back and people have a lot of back pain and they don't have a good outcome. So not everybody's a candidate for that surgery. So laminoplasty is really surgery for decompression of the spinal cord. So if you put pressure on your spinal cord slowly over time, if you develop stenosis or that narrowing slowly over time, the spinal cord will eventually start to dysfunction. And people get a constellation of symptoms that can start mild but then can progress. But in general, people notice that their balance is off. They walk with a funny gait or a spastic gait. Their hands start to go numb, or their arms, their fingers don't work right. Their hands get all clumsy. And then they end up seeing us in the office and their reflexes are really brisk. They're very spastic from pressure on their spinal cord. So patients that have myelopathy, that's called myelopathy. The treatment for that is surgical. That tends to progress and get worse and can cause a lot of dysfunction, so we need to fix that. In this type of surgery, which I described a little before, we can make more space for your spinal cord without fusing your neck. So this is the bone in the back of the spine called the lamina. The hole in the middle is where your spinal cord lives. And this is the vertebral body here. So you can make a cut in this lamina of full thickness, partial cut on that side, and kind of crack that open and hold it open with a plate. And that makes more room for your spinal cord. So not everybody is a candidate for that surgery. There's specific parameters, neck alignment parameters, pre-existing neck pain. There's other factors on who needs this surgery. Otherwise, you need to completely remove the lamina, and we put screws and rods and fuse your neck. So if we can preserve motion, we prefer to do that, but in some cases, you just need to do a fusion. So I'll talk to you a little about some minimally invasive stuff. I've been doing this for 11 years now, and the longer I do this, the more ways I find to do things through smaller incisions with less soft tissue destruction, less muscle destruction, which tends to help in terms of faster recovery, less blood loss, shorter time in the hospital, less use of opiate pain medications after surgery, and a less chance that you remain on them long term. less chance of infection. So those are all the advantages of doing a less invasive type surgery. This is an example of one where we can achieve a lumbar fusion similar to that picture you saw earlier through small incisions. And we can get to the front of the spine and put screws in the back of the spine without moving the position of the patient. So this is called a single position lateral lumbar interbody fusion. So this is an intraoperative photo. This is the patient's back. Their legs are down here. This would be their buttocks. This is the side or the flank right above your pelvis bone. Okay? So we can put a patient on their side like that, left side up. In the first part of that operation, we can make a small incision on your side, shown here. We can minimally disrupt these abdominal muscles, basically split them in line with their fibers. And we get behind the intestinal content, the belly contents, your intestines, and we can get to the side of the spine. And then from there, we can remove the entire disc and put a spacer in, which you're seeing here. And we can distract that disc space back open. We can shift a slip disc forward. We put bone graft in the middle of the cage, which will eventually fuse together. And with the patient in the same position, we can put in what we call percutaneous pedicle screws. We're making a small incision on the back here, and we basically put a cannula through the part of the bone where the screw needs to go, and then a guide wire through that cannula, and then we can pass the screw right over top of the guide wire, right where it needs to go, and we do that under image guidance. So the final product looks something like this. You can see this is the L5 vertebral body. This is L4. You can see this, there's a step off here. This is sliding forward. So as we mentioned before, if the spine starts to translate, the bones in the back of the spine will translate into the canal and pinch your nerves. And really the problem here is not so, it's an instability issue with the spine shifting into the nerves. So if we put the spine back into position and hold it there, we'll take pressure off your nerves and get rid of those symptoms. So we can indirectly decompress your nerves without opening you up in the back, dissecting all the muscle off the bone in the back of the spine, removing all the bone and doing a laminectomy, working around the nerve sac filled with fluid that you could potentially cause a spinal fluid leak. So that we don't have to do any of that. We just have to realign the spine, put it back where it belongs, and hold it there, and that'll get rid of your symptoms. So the X-ray, when we're done, looks like this. You can see the cage here. It's a plastic cage, so you can't see it per se. There's little radio opaque markers that show you where it's at. There's bone in the middle is the fuzzy stuff. These are the screws, and then connected with rods. 2 screws on each side. But that surgery now takes us, we used to have to flip the patient, do the front part, the side part, and flip them over and put the screws in the back. But in a single position, saves us probably about an hour, maybe 45 minutes of anesthesia time that you're under anesthesia. There's less shifting around of sterile stuff in the room. You don't have to take a thing down and set it back up, so less chance that you cause a sterility issue, which increases your risk of infection. So an anterior lumbar interbody fusion is a way of getting down to the L5S1 disc. So you can't go through the side here because your pelvis is in the way. So you got to go more towards the front of the belly to get to it. So if you have a slip at that level and it's pinching on your nerves, we can get to that level now through a small incision here up on the side, and we come at it obliquely. We put the patient on their side once again, and we can get down to L5S1 obliquely with these special retractors. We get in between the iliac vessels here. So this is the end of your aorta where it bifurcates, and you can access that disc and remove the disc, put it in your cage, and realign the spine. And with the patient in the same position, we can put the screws in the back to back that up. Now so here's a good example of that. This is kind of an extreme example. Unfortunately, most of my patients don't have a slip that big, but you can see how far, this is actually L4 and L5, how far L4 is slid off. I mean, it's almost completely off, as you can see. So in days past, we would have had to open this patient up, big incision in the back, remove a bunch of bone, put screws in, try to pull the spine back, try to get cages in here. It's really hard to get a cage in from the back when there's only that much bone overlapping. But for this patient, we were able to go through the front and access the front of the spine here and start to remove this disc and slowly start to push this bone back into position. And we got it back, you know, almost perfect. This is a cage, and it's got screws that are integral to the cage. They actually go through part of the cage and into the bone. And we were able to hold that in that position and then get the screws in the back, which back up this cage and allow it to fuse in the front. So through several small incisions, we were able to realign this patient's spine, get the pressure off her nerves, the nerve pain went away, the back pain went away. In the hospital, 2 days compared to like 4 days, minimal blood loss, minimal use of pain medications after, recovered very well and very quickly and got back to normal pretty fast. And as you can imagine, this person was pretty miserable. Kyphoplasty is probably something you've all heard about. It's a treatment for compression fractures. And usually, people that have osteoporosis, they can even cough, sneeze, but often it's a fall and compress a vertebral body. And if it's terribly painful, it's an option to do this operation. Not everybody has to have a kyphoplasty, but it's a simple operation. We basically put a cannula into the bone, blow up a balloon, and inject some bone cement. It's not my favorite operation. In the literature, at best, it's about 75% effective. Most of the surgeries we do are 90% plus effective. In some of these cases, we end up doing all this, and then it kind of collapses again, or you make this really hard at this level, and then this one wants to compress. So we do, you do 10 of these, 2 or 3 of them, they're kind of the same. They don't get much better. So it can help people. Not everybody has to have this. These can heal on their own, but in patients that aren't doing well, are just not making improvement, they're not able to get up and do stuff, it's a decent option to try to get their fracture pain better and get them up moving. This is an X-ray example. The white is depicting the bone cement that was injected in the vertebral body. This is my last case. This is one of my patients. So we're able to do some scoliosis correction surgeries in a minimally invasive fashion. So scoliosis is a curvature of the spine. Now you can have some minor curvature and really not have too much of a problem. If you start getting a bigger curvature and you're out of balance, like Dr. Gemma was talking about the importance of balance, it can cause a lot of problems for patients. So you can see on this patient, her spine curves to the left, and if you draw a line from the center of the sacrum, so her head and shoulders is left of the center of gravity. So that's difficult because if you had to stand like this all day and your weight is not over your pelvis, your muscles really have to fight to keep you upright. If she was a statue, we'd let her go, she'd fall over. If you look at this patient from the side, you drop a plumb line from C7, so her head and neck are centered out in front of the pelvis. It should line up. You should draw this line up, and this should be your head. So if your head and shoulders are centered out in front of your pelvis, you're fighting all day with your back muscles not to fall forward. So this can be a miserable situation for people. And on top of that, as your spine starts to curve down here, because the discs are collapsing asymmetrically to one side, it can pinch the nerve roots and people get pain down their leg. So this patient had all this stuff going on. So what we were able to do is through several smaller incisions here, put those cages in that lateral lumbar interbody fusion procedure. Same operation, we just did it at multiple levels. So 1, 2, 3 of those, and then the A-lift at the bottom. So we can do that all now, the patient in one position, go to the front, go through the side, get all the cages in. That straightens the spine up. And then usually we'll come back 2 days later and do it in a staged fashion. Otherwise, you're looking at like 12 hours of surgery. Come back at another 2 days later, and then through small incisions on the back, we can put all these screws in and then fish a rod under the skin and lock it all in. And we can get that sort of correction without doing some big open case with 2 liters of blood loss and removal of a bunch of bone and other things. So in conclusion, sort of my philosophy, do all this stuff first if you can. If you're not having a major issue, no significant neurologic deficits, you need to really try to get better without surgery. That's always the first thing you need to try. If that fails, then you need to come see a surgeon. It should really never be the first step. There are cases where people need surgery right away, and hopefully we have ways of trying to get those patients triaged to see a surgeon immediately, or you may see like Dr. Engel, and within the first few minutes he's going to be telling you, no, you need to go down the hall and see me instead. That this is a worse problem than we thought. Most of the surgeries we do are elective, meaning we treat patients for a period of time. They're not getting better, then we make a decision. Should you have an operation? And there's a lot of factors that go into that. It's not an easy decision. But basically, surgery is worth it when the benefits of that surgery clearly outweigh the risks. So if it's a surgery that we can do and we can make you a lot better, make you feel better, get rid of your pain, get you up walking again, and there's minimal risk, and then that's a no-brainer. If you have a lot of medical problems, heart disease, then that could be an issue and make it risky. Now, some modifiable risk factors that we really need to pay close attention to is, people with diabetes. If their blood sugars are uncontrolled, their risk of infection goes way up. So we like to have their BMI under 7.5. If your BMI is over 40, or your A1C is less than 7.5, if your BMI is over 40, technically that's morbid obesity, and that puts you at risk for complications after surgery. So for elective spine surgery, studies have shown that you have less risk of complication under a BMI of 40, so we'll insist that you lose weight because that makes it safer for the patient, and it makes for a better surgical outcome. If you have a failed back surgery, it's going to be worse than what you had before when you started. So the last thing you want is a failed back surgery. And smoking is one of the modifiable risk factors that really works against bone healing and can prevent a fusion from happening. So if we're doing a fusion and you're smoking the whole time and it fails, that's something that could have easily been mitigated by having the patient quit smoking. So if we're trying to get a fusion, we have to have patients not smoking in order to maximize our chance of a good outcome. Like we said, there are some cases where you just need to go right to surgery. And once again, I'll reiterate, the nice thing here about Southwoods, it's not just one person. There's a team of physicians that do different things. You don't have to wait a long time to see me if you just need some therapy and maybe an injection. We can get you in, get you treated. If it looks like you do need to see a surgeon, we can get you over to that person. We can collaborate, we can talk to each other. We should have access to all each other's medical records, which makes it easy. So it's more a comprehensive approach to patient care. All right, that concludes. I think we'll take some questions was the plan.